Asmita?
Yes, ma'am. We just wait for 4 to 5 minutes. People are joining.
Okay.
People are joining, so we are waiting for them.
We shall start, Josna. I think we'll be on time. And stuff.
If they're joining Saraswati, we will give just another 30 seconds to 1 minute.
All right. Okay. Yes.
Minutes.
Vishal? Yes. Shall we start, Josna? Did you say something?
I think we should.
Good morning, everyone. After a successful debut session, it gives me great pleasure to welcome you all to the second session of the Indian Academy of Neurology Young Neurology Forum. So myself, Dr. Saraswati Nashi, Chair, and Dr. Josna, the convener. We are privileged to have you all here. We are honored to have Professor Sangeeta Yoganathan, Madam, Professor of Pediatric Neurology from CMC Vellore, who will be moderating the first case and the serial moderator for this session. I also invite Dr. Vaishak Anand, Associate Professor of Pediatric Neurology from AIMS Kochi. We are also fortunate to have Dr. Muthukumaran P., who is a consultant neurologist, interventional neurologist from PS Neurocenter Tirunelveli, and also Dr. Ujjwal Yole, who is a consultant neurosurgeon and a gamma knife radiosurgeon from KIMS Hospital, Thane, Maharashtra. So welcome you all.
We thank Dr. Vaishak for giving us. Thank you. We thank Dr. Vaishak for giving us the wonderful case, the first case. We thank Dr. Santosh Das and Dr. Nikhilesh Pradhan, both from Kalinga Institute of Medical Sciences, Odisha, for contributing their case. And I especially welcome and thank Dr. Sarvesh Tiwari. He is the Associate Professor of Neuroimaging and International Radiology at AIMS Jodhpur. Thank you all for contributing your cases. And without wasting much time, and please stay tuned till the end of the session. We have two very interesting cases, and the second case also is going to be a very brilliant academic case. And we have an interesting announcement to make at the end of this session about our next session. So stay tuned and looking forward to a very great session. Dr. Sangeeta, Madam, please take over the proceedings.
Yeah. Good morning, everyone. We will proceed with our first case. Dr. Satyesh will be presenting the first case.
Good morning, everyone. At the onset, I would like to thank everyone for giving me this wonderful opportunity. Today, we're going to discuss an interesting case titled Ascension Sans Inflammation, a rare treatable GBS mimic. We present a 14-year-old female child, first of non-consanguineous marriage, on a background of uneventful antenatal and perinatal period, who was brought with chief complaints of generalized muscle pain, more over the back and lower limbs, which was lasting for 3 weeks, and weakness of the lower limbs, followed by the upper limbs, which started 2 weeks prior to presenting to our hospital. The symptom onset was with a feeling of generalized body pain, more over the lower limbs, associated with decreased activity. She was completely ambulatory at the time of her symptom onset. She was going to school. She was a normal child. And 2 days after the body pain started, she had a mild to moderate grade fever which was present throughout the day and which was associated with some vague URI symptoms like dry cough and nasal congestion. She was ambulatory and performing the activities of daily life at the time of symptom onset, as I have noticed. 2 days post the fever onset, she was noted to be more lethargic with complaints of increased pain, especially over bilateral thighs and calves. She wasn't able to run, but she was able to walk slowly without support, and she was still doing activities of daily life. There was no other significant signs of any infection at that point. The dry cough persisted. By the end of the first week, they started noticing that her gait has regressed. She was not able to lift her lower limbs and initially, and by the end of that particular day, she was not able to lift her upper limbs against gravity as well, and she was admitted to an outside hospital. Within 24 hours, she was noted to have poor cough. She was noted to have neck weakness. She was not able to lift her neck when lying down, and hence she was electively intubated and mechanically ventilated, and she was treated. But since she was not improving, she was referred to us for further management. On further digressing the history, there was no history of any bowel or bladder incontinence, no history of any altered sensorium or seizures. There was no history of any deviation of the angle of mouth, no history of numbness or paresthesias. There was no history of any skin rashes, joint swelling, or restriction of movements at the joints. There is no history of any prior photosensitivity. There was no history of any snake bite, insect bite, or animal bite. There was no history of any abdominal pain, diarrhea, pigmenturia, reduced urinary output, or signs of any bleeding manifestations. Past history, nothing significant. There was no history of any fever-associated weakness or muscle pain prior to these symptoms. There was no prior history of any ptosis or ophthalmoplegia. There was no prior history of exercise or fasting-associated muscle pain or weakness. Her antenatal and perinatal period was fairly normal. She was age appropriate for development. She was good at physical activities and outdoor sports as well. There was no similar complaints in the family. At the time of presentation, she was attending school. She was in 8th standard with good scholastic performance. So giving you a brief timeline about the symptom course. It started on the 27th of September, started with generalized muscle pain, fever onset 2 days later with vague URI symptoms. And by around 2 weeks, the myalgia and tiredness continued. She was ambulatory but walking with support. Initial CNS examination showed no localizing signs. DTRs were barely elicitable. She was admitted to PICU. There, she was having a worsening clinical condition with weakness noted initially in the lower limbs, then in the upper limbs, with complete absence of DTRs. And in view of impending bulbar weakness, she was intubated. She was treated with IVIG, IVMP, but her clinical condition was not improving, and she was referred to AIMS almost into the 3rd week of her illness. The initial differentials considered in view of an presentation with muscle pain and then initial onset of lower limb weakness, then ascending to upper limb and bulbar weakness. So GBS was thought of. Along with GBS, the other differentials were an acute transverse myelitis and inflammatory myositis, since an associated fever was also present. She was evaluated extensively and treated with broad spectrum antibiotics, IVIG and IVMP, but her clinical condition did not improve, and hence she was referred to Amrita Institute of Medical Sciences for further workup. So in summary, we have a 14-year-old girl born out of a non-consanguineous marriage with uneventful perinatal and past history, age-appropriate development, brought with acute onset lower limb and back predominant generalized pain, ascending weakness initially involving the lower limbs, then the upper limbs and bulbar weakness. No history of any significant encephalopathy, no ptosis, no ophthalmoplegia, no diurnal variation of symptoms, no history of any significant sensory symptoms, and no bowel and bladder involvement. So at this juncture, given the history and the clinical course, the thought process was GBS or an acute transverse myelitis or an infection-associated significant myositis. When we received the child, on examination, she was intubated and mechanically ventilated. She was completely alert, responding to commands. Vitals were stable. On anthropometry, her weight was 27
Dr.
kg.
Satyesh,
Sir.
I think before going to the examination, we can just critically analyze your history. At the end
Okay.
of the history, what are the dates? What is the localization historically that you have?
Historically, given the presentation with ascending weakness with absent DTRs, my initial localization would be plexus or nerves, sir.
You mean radical?
Radical, sir. Yes.
Okay, but if GPS is considered as a prototype of a radical involvement, is the pain, don't you think it's an out of proportion to what we
It
usually
is
see
an
in
out of
GPS?
proportion pain, or one consideration could be that it could be she was having an additional symptom of an secondary infection associated myositis. The second DD that we can consider is a significant infection associated myositis as well. And the third consideration could be a metabolic consideration for her.
A few points in the history, like because she had onset of pain followed by a febrile illness. So was this prior to the onset of the pain? Did she had any prolonged fasting or any exposure to excessive cold and hot weather, or she had some strenuous exercises preceding that?
No,
Did
ma'am.
she have any muscle cramps and stiffness of the muscle?
No, ma'am. We asked for the history. There was no significant fasting, no significant travel history, no significant exertion history, no history of any significant cramps or any fixed weakness also for her prior to the onset of the symptoms.
With regard to her sports activity at school, because she is a pre-morbidly normal child, was she able to participate in the sports activities like other peer group children, or she was a slow runner at school and she had some kind of a mild
She was
exercise?
she was playing handball, ma'am, and also she used to sprint, but mother did not give any significant history that she was lagging compared to the peers.
Okay. So your anatomical sites of localization based on this history is like you considered a nerve and you also considered the muscle, right?
Yes, ma'am. Initial consideration based on the symptoms would be radiculopathy. Then the second localization I would keep as a muscle.
Okay. So what possible etiological consideration you had at this point?
Etiology for the muscle, ma'am.
Yeah.
Since she's an adolescent child and there is a significant onset of pain, which is a key consideration here. An underlying inflammatory etiology, I would like to consider first, like a JDM or a polymyositis. And the second consideration would be a metabolic etiology, like a slow unmasking of a late onset metabolic etiology or a mitochondrial etiology.
Would you not consider an infection associated because which is
Yes,
more
ma'am.
rapid, like
Infection associated also. Apart from these, from the infection associated myositis, I would consider the other two also.
because the odd point for inflammatory myositis is it's too rapid, like 2 weeks and 3 weeks she developed bulbar weakness, which is not the usual scenario.
Yes, ma'am.
Yeah, please proceed. Vaishak, do you have any other questions?
Any
So
vascular event can be considered.
But vascular, she was not having any focal deficits. The other thing is there was no history of any significant pigmenturia. There was no other significant history for her to say it is a vascular thing. No signs of any rashes, petechiae, purpura.
and any extra neurological cause be attributed to kind of this much of an out of proportion pain followed by paralysis?
Uh, Significant pain and all, porphyria can be one of the causes, sir.
Okay, but
Again, there was no history
porphyriosis,
of any photosensitivity. There was no history of any significant sensory symptoms for her.
yeah, porphyriosis paralysis due to nerve involvement, right?
Mm.
I'm
Yes.
asking, is there any extra neurological, any other musculoskeletal cause can present like this, like a
Uh,
pseudo paralysis?
Significant nutritional deficiencies like scurvy and all can cause, but her diet is fairly good. There was no food faddism for her, and no significant exposure to animals if we are considering a zoonotic infection like a rabies or anything.
Okay. Okay. Proceed. You also mentioned that there is no history of any snake bite and all.
Yes, sir.
So anyway, this history is like almost in 3 weeks, right? The NADL
Yes,
was into 3 weeks.
yes, sir.
If it was an acute presentation, like within 2, 3 days, the child reached an adult with the absence of you have asked the snake bite history, but it's not there. Will that rule out a snake bite?
No, sir, it won't rule out because some snake bites can be fairly subtle. Like if it's a crate bite and all, usually the chances of it missing are more.
Okay, yeah. So some way of
Yes, sir.
some cases
Yes, sir.
One of, one other possibility you could consider is, sorry.
gets up in the midnight. It turned out to be great by time. Okay, you can.
Yes.
Another possibility which you could consider is like a non-dystrophic myotonias, channelopathies, which can present
Channelopathy.
episodic weakness, fluctuating weakness.
Yes, ma'am.
Yeah, please proceed.
On examination, when we first received the child, she was intubated and mechanically ventilated. She was alert, responding to commands. Her vitals were stable. On anthropometry, weight was 27 kg, less than the first centile. Height was 148 centimeters. Here, in this case, it was the length. Head circumference was 53 centimeters. Both were within normal limits. On general examination, there was no pallor, icterus, no rashes over the limbs or around the eyes, no swelling of the joints noted. There was no significant lymphadenopathy. On CNS examination, GCS was E4, VT, E6. She was oriented and responding to commands. On cranial nerve testing, pupillary reflex, pupils were bilaterally equal and reactive. Her extraocular movements were full. There was no nystagmus or no ophthalmoplegia. Face was bilaterally symmetrical and there were no signs of any facial nerve involvement. When adjusting the ET tube, there was a gag. On motor examination, bulk, there was generalized thinning noted. There was significant hypotonia. On power testing, neck power was less than 3 by 5. Upper limb proximal was around 2 by 5. And elbow power was both flexion and extension was less than 3 by 5. Distal hand grip, however, was good with wrist flexion and extension more than 3 by 5. Lower limb hip flexors were 2 by 5. Extensors could not be evaluated. Knee flexion was 2 by 5. Extension was 2 by 5. Foot dorsiflexion and plantar flexion were 2 by 5. Inversion and eversion were also 2 by 5. On sensory system examination, there were no focal deficits in pain, temperature, and vibration testing. DTRs were absent in bilateral lower limbs and were difficult to elicit in the upper limbs. There was no Babinski response. There were no involuntary movements, no signs of nystagmus or incoordination in the upper limb movements. On systemic examination, the respiratory system was fairly normal except for frequent conducted sounds. On abdominal examination, there was significant hepatomegaly and the liver was palpable 4 centimeters below the right costal margin, which was soft and non-tender. There was significant epigastric tenderness. No guarding or rigidity was noted. On cardiac examination, S1 and S2 were present and no pathological murmurs were noted. So based on the history and her course, the localization possibilities that we have thought, the first was muscle because of the points that we have discussed before. And the etiologies in the muscle were inflammatory myositis like a JDM or a polymyositis. However, there were no rashes, there was no significant joint affection, the DTRs were absent, and these are the points against it. And considering a metabolic myopathy like glycogen storage disorder or a fatty acid oxidation disorder, a mitochondrial myopathy or Tango 2 myopathy. There was no history of any exercise associated worsening in the past. There was no history of any fever associated worsening in the past, and there's no history of any pigmenturia or myoglobinuria. Channelopathies, as Madam has suggested, are another etiology. But her blood labs, electrolytes were normal. There were no prior episodes of any episodic weakness, and the subacute progression of the weakness is also against this. Then the second possibility that we thought of was a radicular involvement like a GBS or a CIDP or porphyria. However, there was no response to IVIG which was given in the previous hospital, and there was out of proportion limb pain again, which was not correlating well. Then an anterior horn cell or a spinal cord involvement, since there was history of severe history of an acute onset fever, which was going in tandem with the symptom presentation. We thought of an acute transverse myelitis, whether an infectious or demyelinating, usually viral associated, or a remote possibility of an ASA thrombosis. But again, the points against are severe limb pain, there's bowel and bladder sparing and no sensory involvement. And neuromuscular junction, where myasthenia gravis, an unmasking of an myasthenia gravis is also a possibility, and a snake bite is considered. But again, the points against this are there's significant pain, there's no ptosis of ophthalmoplegia, there's no diurnal variation in her symptoms, snake bite history, and also the DT as well. Coming to the investigations, we have reviewed the labs which were done.
Before you proceed to investigation, any structural lesion like malignancy or can be considered?
Malignancy causing so much pain at this age group, usually hematological malignancies and all, but again, nothing significant for her, sir. And even for any spinal cord tumors or something, the sensory system examination was grossly normal, even if you are thinking of a compressive myelopathy.
Dr. Santosh has raised his hand, so
In the GBS, so GBS is your first consideration. No, so GBS is your second consideration. So in the GBS, so can nodopathies, paranodopathies like Casper 2 can have a similar presentation because severe
Yes, sir.
pain is out of proportion.
Yes, sir. Severe pain and all nodopathies can also be a presentation. Again, a point which is in favor to a nodopathy is the lack of response to IVIG also.
My question is why you consider muscle disease as the first possibility and that too juvenile dermatomyositis?
Because the initial presentation was a significant pain, sir. It was a generalized myalgia, not just the lower limbs, and which was more of a lower limb predominant and back predominant muscle pain. And along with this, she was slowly, the course was also fairly slow. She was initially very ambulatory and she was slowly.
But your total duration to intubation, from the presentation to intubation, how many days? 3
Weeks,
weeks. 3 weeks, na?
Yes, sir.
So 3 weeks juvenile dermatomyositis, so rapidly patient need intubation and mechanical ventilation. I think it is for a inflammatory myopathy to intubate within 3 weeks. I think that is the very odd point. Even if
Yes, sir.
myalgia is a prominent symptom, it may happen in GBS also, but to intubation within 3 weeks time requirement, considering juvenile dermatomyositis or any inflammatory myopathy, unless it is a very necrotizing myopathy type of thing, I think slightly odd for juvenile dermatomyositis to consider.
Okay.
Thank you.
Are very rare subtypes like NTNXP2, which probably worsen faster. Though 3 weeks, I agree, is very fast. Some rare subtypes can come with a lot of weakness and contractures in a short duration. But I totally agree, it is quite fast. But we have some rarer subtypes like NXP2.
Yeah, among the metabolic myopathies too, like the muscle is a high energy demand organ, so it derives energy from glycolysis, glycogenolysis, phosphocreatine pathway, and adenylate kinase enzyme through the purinucleotide pathway, and you have the major source of energy from beta oxidation and oxidative phosphorylation. So any of these enzyme defects can result in fluctuating episodic weakness, or they can have a chronic progressive weakness. So you, at this point of examination, like you can't pinpoint like which actually is the pathway involved. Maybe further investigations will help you to narrow down the metabolic cause.
Shall I go ahead?
Yeah.
So we have reviewed the labs which were done at the first admission when she was admitted outside, which showed a significant elevation of CPK, which was in 18,000s, along with a significant elevation of LDH and transaminitis. AST was in 4,000 and ALT was in 1,000 plus range. The GLAC, that is serum glucose, electrolytes, arterial lactate, ammonia, blood gas, and urinary ketone testing was within normal limits. Her inflammatory markers were also fairly within normal limits. Serial testing revealed a significant elevated CPK and LDH. Other inflammatory markers like ferritin were also within normal limits. Urine myoglobin testing was negative. Etiology specific workup like the common viral pathogens like dengue, hepatitis E, A, B, E, C, respiratory viral panel testing, MAN2 testing, wheel Felix, rickettsial scrub IgM, serum were all within normal limits. Serum Ig level was also within normal limits. B12 folate levels and uric acid were also within normal limits. And since there was a significant elevation of LDH, they've done a DCT, which was also negative, and coagulation parameters were also within normal limits. Further systemic evaluation, echo showed a mild LV dysfunction. ECG showed no signs of rhythm abnormalities. Since she had a new onset abdominal pain into the course of her PICU stay in the first hospital, and an ultrasound revealed a bulky head of pancreas, and repeat labs showed elevated lipase, amylase, and moderate elevation of ammonia. A CSF analysis was done, which showed an elevated lactic acid of 53 milligrams per deciliter. The reference range is between 10 to 22. Protein was within normal limits. Total count was also normal, and meningoencephalitis panel testing was negative. She was treated with broad spectrum antibiotics and N-acetylcysteine. We have repeated the labs. The random glucose was normal. Electrolytes were within normal limits. Serum ammonia and lactate levels were normal. There was transaminitis, but it was on a slightly lower scale, lower intensity compared to the outside elevations. Serum ketones were negative. CK was elevated. LDH was elevated. Amylase lipase was also elevated. The thyroid profile, TSH was normal. T3, T4 was also within normal limits. And the etiology workup, including the infective etiology, everything was normal. CSF, we have repeated, glucose was 80 and the corresponding RBS was 110. There was no hypoglycemia. Protein and lactate were also within normal limits. So at this point, given the significant elevation of CPK, transaminitis, and elevation of amylase lipase, there was a systemic involvement. So a strong underlying immune etiology was considered. And given her age, a metabolic myopathy with systemic affection was also considered likely. The common causes here are either a fatty acid oxidation defect or a mitochondrial myopathy, and the remote possibility of an ascending paralysis with absent GBS, absent reflexes, where a GBS and nodopathy could still be a possibility. NCS showed
There is one
reduced.
question, Satish. Why did you do a B12 level and folic acid in the case when the CPK was 18,000? One of the participant has asked.
One is the initially the outside LDH was also elevated, ma'am, and on top of that, the outside NCS was also slightly abnormal. So we just wanted to do a complete panel workup to see if there is any treatable causes for an underlying neuropathy for her as well.
Okay.
NCS showed reduced CMAPs from bilateral peroneal and tibial nerves, as you can see here, and sensory conduction showed reduced snaps from the right saphenous and absent snaps from the left saphenous nerve, and rest of the conduction parameters were within normal limits. There was no evidence of any conduction block here. Again, these are mild abnormalities, not pointing significantly towards any particular etiology at this point. Further workup, ultrasound showed hepatomegaly with mild fatty infiltration. Pancreatic head and uncinate process were bulky. No significant signs of an acute pancreatitis. Pediatric cardiac evaluation showed a normal echo. EEG was done, which showed no epileptiform abnormalities. Rheumatology opinion was sought. The anti-myositis antibody profile testing was done, and ANA testing was done. Both were negative. At this point, we have done a neuroimaging as well, which showed Bilateral T2 and flare hyperintensities in the periventricular deep and subcortical white matter of frontal and parietal lobes with diffusion restriction. There was no post-contrast enhancement seen in any of the CNS lesions, and the MRI spine was grossly normal with no significant contrast enhancement of the radicals.
Why did you plan a brain MRI in the child who presented with the pure element syndrome?
Because our one of the DDs considered was a mitochondrial myopathy also, ma'am. So since mitochondrial myopathies can have CNS changes, we have considered CNS imaging as well.
But your initial lactate, everything was normal. Lactate, ammonia, all parameters were normal.
Yes, ma'am. But she has come from an outside hospital where she was treated for some time. So possibly that lactate values could be could be varying with fluid in
Did
intake
you
and
have
all.
CSF lactate level 2?
Our lactate level was normal, ma'am.
CSF.
Yes, ma'am. CSF lactate level was also normal.
And brain MRS was done?
No, ma'am. MRS was not done for her.
You considered mitochondrial as a differential, but still you did not do a brain MRS?
This initial brain imaging was from an outside hospital, ma'am. So that MRS sequencing was not available at that point.
Okay.
So we went ahead and since we thought of an underlying immune etiology and also a metabolic etiology was considered, we went ahead and did a whole body MRI focusing on the lower limb, focusing predominantly on the lower limbs in the body, which showed significant muscle edema seen as stir bright signals involving gluteal muscles, iliacus, anterior and medial compartment of the thigh, suggestive of myositis. And there were T2 hyperintense lesions noted in bilateral kidneys, which were suggestive of cystic lesions, as you can see here in both the kidneys. And when we went back retrospectively and reviewed the first MRI, these changes were present in the first MRI as well. So now three axes are involved, which are the brain, nerves, and muscle, along with a significant systemic affection. There was mild LV dysfunction, there was transaminitis, and an elevated pancreatic enzymes. So at this juncture, the possibility of an immune myositis or a metabolic myopathy with systemic affection were much more likely. And in metabolic, we were strongly suspecting a fatty acid oxidation defect or a mitochondrial myopathy. So her course at admission, she was by day 6 she was extubated and she was started on NG feeds and she was slowly improving. Since we thought of an underlying immune etiology and she has already received IVMP outside, we continued oral steroids at 1 mg per kg per day as an underlying metabolic etiology was considered. We started her on high dose riboflavin, carnitine, and CoQ. Udiliv and antacids were continued, and slow initiation of physiotherapy was also done. She was shifted to HDU by the second week and started on oral feeds after a swallow study. Serial labs showed resolving transaminitis and lipase. And by the second week, her abdominal pain resolved with weakness of lower limbs improving, and she was tolerating full oral feeds. And by the third week, she was ready for discharge. She was able to sit without support, stand with minimal support, and walk a few steps with support. Her upper limb power also improved. Proximal was more than 3 by 5, distal was 4 by 5. Lower limb proximal power was around 2 by 5, distal was 3 by 5, and toe grip was weak.
Yeah, among the fatty acid oxidation defect, which can present with acute onset muscle weakness, CPT2 deficiency, BLK deficiency, LCHA deficiency, trifunctional protein deficiency, and multiple acyl CoA dehydrogenase deficiency. So there are these five enzymes which can present with acute onset muscle weakness. So how did you pinpoint to MAD deficiency? Because this is the neuropathy can occur with LCHA deficiency, trifunctional protein deficiency, and MAD deficiency too. And you can have systemic involvement in terms of cardiac, other system involvement, and CPT2 deficiency too. So how did you pinpoint to MAD deficiency at this point?
MAD initially we were thinking because one is the age of onset, ma'am. The type, the late onset GA2 is well known to present with
Late onset CPT2 also can have LCHAT, and trifunctional protein also can have late onset symptoms. So all these depending upon the underlying mutation, like if they have like a residual enzyme activity which is very less or null activity, then they manifest in the neonatal period or infantile period. Otherwise, if they have a residual enzyme activity, they can manifest later. It's very difficult to identify at this point specific enzyme defect unless you have the enzyme activity estimated in the muscle or in the if you have done an enzyme analysis in the fibroblasts.
Okay. Further differentiation, I'm not very sure, ma'am, how to.
Okay, please proceed. Did the child have any retinopathy? Because that would be one of the differentiating feature on the clinical finding. If you have a neuropathy with retinopathy along with muscle weakness, you should consider a LCHA deficiency and dry functional protein deficiency.
No, ma'am, she did not have any retinopathy. Ophthal examination, including fundus, was normal in the
And
hospital.
ECG, there was no evidence of any arrhythmia or Brugada
No,
pattern.
no, ma'am.
Okay. So the most important thing at this point, which will help you to differentiate, is the urine GCMS and the acyl carnitine profile. Do you have the reports of those?
No, ma'am. That reports they were actually sent, but we couldn't source those reports from them.
Okay, so then it would be difficult to pinpoint to a particular enzyme defect at this point unless you have the genetic diagnosis. Please proceed.
So muscle biopsy was sent during her PICU stay. And this is the image of the muscle biopsy, which shows muscle fibers with mild variation in fiber size. There's features of active myopathy where you have myophagocytosis and myonecrosis in between. And multiple small vacuoles are seen in scattered myofibers. These, when stained with oil red O, however, this is not a fresh specimen. This oil red O testing was done on the paraffin muscle stains, which still showed suspicious globular deposits within the myofibers, which is more pointing towards a fat accumulation within the muscle. And we have sent a whole exome with mitochondrial panel testing, which confirmed our suspicion. And this was suggestive of a compound heterozygous autosomal recessive pathogenic and likely pathogenic mutation in the ETFDH gene causing glutaric aciduria type 2. Maternal analysis showed the exon 3 variant. However, the exon 9 variant was not detected, and the father sample was not available for testing at the time of admission. Mitochondrial DNA analysis revealed no significant mutations further.
You expect both variant to be present at mother? It's a compound
Uh,
heterozygous mutation.
yes, ma'am. But it usually we see one variant from the one parent and the other variation from the other parent.
Can you have both the variants from one parent and another parent being normal?
No, ma'am.
You can have it in uniparental disomy.
Okay. So coming to the discussion part, here is a brief overview on approach to generalized weakness in an adolescent. Based on the localizations, if we are dealing with adolescent or a child with generalized weakness, usually think of spinal cord. The significant DDs are a transverse myelitis, spinal cord infarction, a compressive myelopathy, or a traumatic spinal cord injury, or an anterior horn cell can have an acute flaccid myelitis. Plexus involvement, GBS, nodopathies, neuropathies of infectious causes, toxic neuropathies if they are on significant alternative medications, acute intermittent porphyria should be considered. When neuromuscular junction is being taken into account, myasthenia gravis, tick bite paralysis, and botulism can also be considered. Muscle usual causes benign acute childhood myositis, viral myositis. Then we go on to metabolic disorders, channelopathies, rhabdomyolysis, drug-induced paralysis, and systemic diseases like dermatomyositis and polymyositis. Coming to metabolic myopathies, as we know, there are five key sources of energy for the muscle. Glycogen, which is readily available as for short-term bursts of activities. Then you have lipids, which give sustained energy. Then you also have the purine nucleotide cycle and the CK reaction, which converts phosphocreatine to ATP. Uh, all this is done ultimately through the mitochondrial respiratory chain, which is responsible for the oxidative phosphorylation. Uh, whenever we are seeing metabolic myopathies, there are two types of symptoms. One is a dynamic symptoms where you can have muscle cramps, pain, weakness. Usually we see high CPK and myoglobinuria, and these symptoms are precipitated by exercise, prolonged fasting, any stressors like infection or low carbohydrate or high fat diet. And static symptoms, mostly which present as a limb girdle pattern of weakness, and they can involve respiratory muscles and heart as well. So these are a heterogeneous group of genetically determined conditions that may present at any age, and they're characterized by defects in the biochemical pathways of storage, mobilization, utilization of substrates, of energy generation in the muscle. Skeletal, cardiac, and smooth muscle dysfunction, as well as brain and endocrine involvement, can also be seen. Rare entities, these are overall rare entities, however, collectively are common in neurology practice. Coming to metabolic myopathies, the first major subgroup is the glycogen storage disorders. Uh, there are multiple types commonly which we see are GSD2 or Pompe, and then we have the McArdle, GSD7 and Tarui more in the adolescents and the adult group. Usually they are induced by brief isometric exercises like heavy weightlifting or intense exercise, but sustained exercise like swimming or running is also seen. Usually, the symptoms start shortly after the exercise. Few characteristic features like second wind phenomenon, which is seen in GSD5, and an out of wind phenomenon, which can be seen in GSD7. Then the next subgroup is the fatty acid oxidation defects. Uh, CPT2 deficiency predominantly presents with dynamic symptoms, whereas static symptoms are more common in MAD and VLCAD. And these are symptoms are usually induced by stressors, prolonged or intense exercise, and prolonged fasting. And symptoms usually last for hours after the exercise. And recurrent episodes of hypoketotic hypoglycemia can also be seen. And TCMS, GCMS shows altered carnitine profile in majority of these conditions. The third major subgroup is the mitochondrial myopathies, which can present with in a multitude of symptoms and signs. Mostly combined dynamic and static symptoms are seen. The common ones are Golgi and CoQ deficiencies, where exercise intolerance is more prominent than weakness. Usually, we'll see a multisystem and multineuraxial involvement. External ophthalmoplegia and ptosis are quite common. There's also literature evidence of late onset GA2, which is mimicking like GBS. Here we have two case reports, which were presentation was mimicking more of a GBS kind of a presentation. So overall, our case highlights an uncommon presentation of GA2 mimicking an ascending paralysis and respiratory failure. But one key thing about this entity is it has a high degree of suspicion is warranted because riboflavin replacement can significantly improve the outcome, especially in the late onset GA2 forms. And metabolic myopathy should always be included in the differential diagnosis in a patient with episodic weakness, especially in the presence of other organ systems such as hepatic or cardiac involvement. Finally, our patient, she was on regular follow-up since discharge, and she was treated with oral high-dose riboflavin, CoQ, and biotin. She was back to baseline by 1 month post-discharge. Now is going to school, is completely asymptomatic, and is under regular follow-up with a pediatric nephro consult pending for the management of the renal cysts which were diagnosed before.
Sarvesh has some comments. He's a neuroradiologist here.
Yeah, hi. So there was one interesting thing that you showed in ultrasound. There were cysts in the kidney, right?
Yes, sir.
So there were,
Not the ultrasound, sir. MRI showed the.
yeah, cysts were there. Yeah. So in fact, that is one of the findings which is described with your multi-acyl CoA deficiency. It can be massive cysts when it is in the neonatal form,
Yes, sir.
but cyst formation can happen with this condition. So that is one interesting thing that you find associated with this condition. The kidney's size can also be enlarged, so that also could have been looked at.
Yeah.
That is one thing. And in the brain, if you see the kind of pattern that we had in the scan, so it's basically a patchy subcortical white which is getting involved, right? and quite asymmetrical. So mitochondrial could have been, I mean, one of the differential here based on the kind of abnormality that we are seeing, particularly those with cavitating mitochondrial leukoencephalopathies. So those could have been one of the differential. There is definitely a frontal predominant involvement.
Yes.
So that we see in metachromatic leukodystrophies. So storage versus this, we would have thought that the kidney finding was quite interesting. That we were able to make out cysts in the kidney, and kidneys are supposed to be enlarged also in this condition. So that is one point I wanted to raise in the scan.
Yeah, thank you, Dr. Sarvesh. So in this case, actually, this kidney cyst is described in GA2, but what was odd was usually in GA2, it's the early onset, the neonatal onset GA2, the kidney cyst are involved. But as far as we searched, such a kidney cyst in a late onset GA2, we were not able to find. It was
So
quite
it should
surprising
be,
because
it should be described.
it would be a new phenotype. Yeah.
Yes.
Because we didn't actually search for it. We did an MRI scan and it incidentally detected that there is a renal cyst. And then looking back, it actually supported, although it was a late onset GA2.
Yes.
But yes, it was definitely an associated finding.
Cystic dysplastic kidney is not again diagnostic of MAD deficiency alone. It can be found in CPT2 deficiency also. So it's because of the acyl ester accumulation, the long chain fatty acid acyl ester accumulation. They are toxic to the tissues, so which can cause all your malformations and the cardiac arrhythmogenicity. So again, based on the single ultrasound finding having this kind of muscle weakness, the other differential could be CPT2 deficiency too. So unless you have the acyl carnitine profile and urine organic acid, I'm again re-emphasizing on that because that's the one which will help to differentiate the subtypes among the fatty acid oxidation defect. Because in the multiple acyl CoA dehydrogenase deficiency, you will have small chain, medium chain, as well as the long chain. All acyl CoA dehydrogenase activity will be affected. As a result of it, if you see in the acyl carnitine profile, you can see elevation of acyl carnitine esters ranging from small to long chains, like from C2, C4, C6, C8, C10, C12, C14. C16. So it can be like multiple acyl esters elevation on the acyl carnitine. Another thing in the urine organic acid profile, I mean, in the multiple acyl CoA dehydrogenase deficiency, you will have excretion of urine dicarboxylic organic acid. So you will have elevation of, in addition to the lactic acid elevation, you will have elevation of glutaric acid, 2-hydroxyglutaric acid. You will have adipic acid, sebacic acid. So these are the core markers like acyl carnitine analysis along with total free carnitine and the urine organic acid will help to analyze the subtype based on your biochemical markers. So again, the imaging findings are very non-specific and it's not diagnostic for any of this fatty acid oxidation defects. And based on the clinical phenotype, it's very important to identify the exercise intolerance, which is not there in this case. So if you identify that, then you can check whether it is related to like an high intensity short burst exercise, or it is like a prolonged exercise which causes it, which kind again can give you a clue whether it is like a glycogenolysis defect or it is like related to the fatty acid oxidation defect. It's an excellent case, Satyesh. Very well worked up. Satyesh and Vaishak, congratulations on this nice case.
Thank you, ma'am.
Regard to the management aspect, so one most important thing is you have to dietary formulations, like you have to follow a limited fat and protein restricted diet, and also you have to avoid the triggers subsequently, and then you have to supplement riboflavin. The dose would be 100 to 300 milligram per day. And a carnitine level you need to check if it's low total and free carnitine level. If it's low, carnitine supplementation has to be provided 50 to 100 milligram per kg per day in divided doses. And also CoQ is essential for the electron transfer. So coenzyme Q also has to be supplemented. So the dosage should be from 60 to 240 milligram, or otherwise you can give 5 to 10 milligram per kg per day. So this is the main management. Another thing is the testing of the dad in this case, and if any unaffected siblings are there, because this child had a late onset presentation, unaffected siblings are there, they need to be tested.
She was the only child.
Okay.
Yes, ma'am. She is not currently on this high carb, low fat diet and on the supplements riboflavin, CoQ also. And after this first episode, she is completely back to baseline. She never had a trigger again. And this was an interesting case to us also, because initially we thought it's like a garden variety GBS, except for the out of proportion pain. But later, once it was clear that the muscle is the pathology, the discussion was between whether it's an inflammatory myositis versus a metabolic myopathy. I agree that inflammatory myositis like JDM getting intubated in third week is a bit unlikely, but we had some cases like, as Dr. Saraswati mentioned, NXP2 presenting like a metabolic myopathy cases also we had, but still we kept both the possibilities. And initially itself we started the vitamins like riboflavin and added carnitine, CoQ and all. To add to the confusion, this brain finding was there, which initially was like looking like the ITS. ITS is the term that we use in children as an umbrella term to describe all these infection-triggered encephalopathy syndromes like ANAC, fires, etc. But clinically, it was not looking like an encephalopathy syndrome. It was a myositis syndrome. So it was actually not fitting into any of the classical syndrome. But we had kept the possibility of metabolic myopathy along with inflammatory. The steroids already were given from the outside hospital. We continued oral steroids and added the vitamins. And then I should thank the enhanced team for providing the muscle biopsy very early. And then it was confirmed with the exome also. So very well presented, Dr. Satish. So the take-home message was that in cases like typically GBS, we need to consider possibilities of metabolic myopathy because these are treatable entities. So we can start riboflavin or the supplements like CoQ initially itself if there is a slightest doubt of a metabolic myopathy. Thank you.
Yeah, Dr. Nalini here, just 30 seconds. It was a fantastic case. Of course, we had such cases coming like metabolic crisis to our casualty. We would think it's a post-viral myositis because there's some fever triggered. And then altered sensorium with seizures also because fatty acid gets deposited in the brain also. And CKs in lakhs, like 2 lakhs, 3 lakhs we've had. Anyway, it was a super case. I just wanted to ask Dr. Sangeeta, are you going to give, how long would you treat this patient? Is it lifelong or 2 to 3 years? Because there are varied opinions on this.
Yes, ma'am. So for multiple acyl-CoA dehydrogenase, this child is genetically conformed. So we ideally need to keep them on the diet and avoidance of trigger with the supplements on lifelong. Only for the carnitine, we need to keep a tab on the total and free carnitine levels. So because if you give excess of carnitine and if they have more of a like esters, a long chain esters formation, again it might become arrhythmogenic. So particularly for the CP2 deficiency. So for this child, carnitine level free and total carnitine level needs to be monitored and carnitine dose has to be adjusted. The CoQ and riboflavin has to be supplemented lifelong. And the other next most important thing is, as ma'am rightly mentioned, like most of them manifest with an acute illness to the emergency room. So you have to give an emergency management plan for the physicians, because if they may go to the nearby hospital, so they should be able to start 10% dextrose immediately, and then they should avoid intravenous lipid. So if the child has hypoglycemia and they think it's like another any other small molecule IEM, they tend to give a intravenous lipid like for an energy failure. So that should be avoided in these patients. So 10% dextrose, and also like if the child is going to the school and if she's planning for any sports activity, she should be encouraged to take a short scheduled feeds along with carbohydrate containing fluids to avoid energy expenditure and decompensation.
Okay, yeah, thank you. Even I thought that we have to give lifelong. Many of our patients are now on 10 years, 12 years on this maintenance riboflavin only. CoQ10 we're not giving if ETFTH mutation is identified and if it is RR MAT. So just wanted to tell, because this Iranian group, from Iran, you have lots of these cases because of consanguinity. So they give just for 2 to 3 years and then they stop it, it seems. So Dr. I forget his name, in all of these muscle disease meetings, he presents. I think Nafizi Ali, I think his name is. So I just wanted to know our practice. Anyway, thank you. It was a super case, Dr. Satish. Yeah.
Thank you.
Thank you, madam. Thank you to Sangeeta madam, Nalini madam, and all other panelists here. It is cases like this which inspire us to push the boundaries of clinical and academic neurology both. Request Sangeeta madam to please take over the proceedings.
Yeah, we will move on to the next case now. We have another interesting case for discussion. I request the next presenter, Dr. Sujit.
Yes, ma'am. Yes, ma'am. Can I start, ma'am?
Please proceed.
Yeah.
Good morning, everyone, and thank you, sir and ma'am, for giving this opportunity to perform this in this platform. And in this case of quadriparesis in a young lady navigating a diagnostic challenge. And coming to case history, a 38-year-old female from Balasur from Odisha presented with chief complaints of neck pain for 2 months and paresthesias of both upper and lower limbs for 1 month and weakness of both upper and lower limbs for 20 days and urinary disturbances for 20 days. History of presenting illness being neck pain since 1 month, which is insidious in onset and posteriorly located, dull aching and persistent in character, non-radiating and poorly localized pain, and which is not aggravated by any pressure symptoms like cough, sneeze, or straining. And paresthesias of upper and lower limbs since 1 month, which is insidious in onset, gradually progressive in nature. First, initially noticed over the upper trunk and proximal upper limbs, which followed by involvement of distal upper limbs, and subsequently over 2 to 3 days, progressed to lower limbs from proximal to distal region. And she also had complaints of cotton wool sensation while walking and unsteadiness while walking in the dark, and on walking while walking on uneven surfaces, and history of wash basin phenomenon present. And weakness of limbs, which started since 20 days, initially started with weakness of both upper limbs, difficulty in mixing food, unlike predominantly distal involvement, then in form of mixing food and difficulty in buttoning and unbuttoning, and then later progressed to difficulty in lifting arms above the head and difficulty in combing hair. Subsequently, next 2 days, weakness progressed to involve both lower limbs in the form of like distal in the form of difficulty in gripping slippers and difficulty in getting up from sitting position. And patient also had complaints of progressive stiffness and slowness of movements involving both upper and lower limbs associated with difficulty in doing fine hand activities and while walking. And bladder disturbances which started 20 days since 20 days, which is insidious in onset and gradually progressive. Initially started like with complaints of patient is having urinary urgency and increased frequency and then urge incontinence. And there is no history of any drooping of eyelids or any double vision, facial sensory loss or deviation of angle of mouth and difficulty in closing eyelids. No history of swallowing difficulty, nasal regurgitation, and no difficulty in neck movements. And no history of any loss of sensation over the body, like she is able to appreciate clothes and mosquito bites. No history of seizures or altered sensory. No history of fever, rashes, weight loss, or constitutional symptoms. And no history of trauma. No history suggestive of any past history, no history suggestive of any connective tissue disease, and no history of tuberculosis or contact with TB, and no past history of similar neurological illness, no history of any other comorbidities. Coming to case summary, 38-year-old lady presented with neck pain, followed by subacute onset, gradually progressive paresthesias with sensei ataxia, subsequently developed rapidly progressive symmetrical quadriparesis with UMN bladder involvement without cranial nerve and cerebellar involvement. And
Okay.
Dr.
Yeah,
Sujit?
Yeah, Dr.
yes,
Ujjwal. Yes, sir.
Yeah. So you are saying there is a distal to proximal progression of weakness. So it
yes,
started initially in hands and then progressed proximally.
yes, sir.
Okay. What are your localization in terms of anatomical localization and
So for neck pain, anatomical localization, neck pain was initially started with neck pain, then numbness or symptoms of sensory ataxia, and then weakness and bladder involvement. So neck pain can be localized to muscle or any vertebra or facet joint arthropathy or arthritis or any disc prolapse or radiculopathy, and dura covering the cord like any inflammatory meningitis or infective meningitis, and vascular dissections like carotid artery stenosis or tubular artery stenosis.
uh,
And
did
now,
you get any stiffness in the history, stiffness or
yes, yes,
spasticity? Like,
yes, sir. She complained the specific history was there, and I have included in the histories. Uh,
okay.
she she complained of spasticity in both lower limbs and upper limbs, predominantly in lower limbs than upper limbs.
Okay. And any difficulty in walking up or down the stairs?
Yes, sir. She gave the history of difficulty in walking or climbing over the stairs.
Fine. So what is your localization?
Sir. For initially, she had that history of sensory symptoms started in the upper limbs and then progressed to lower limbs. One thing is with the history of difficulty of walking in uneven surfaces or swaying in darkness. One thing is posterior column involvement is the localization like involvement of posterior column, and then weakness of upper limb and lower limb where we can think of corticospinal tract, and involvement of history of involvement of bladder like urgency or increased frequency and urge incontinence, descending autonomic pathways of spinal cord involving the bladder involvement, which in the form of UMN bladder.
So complete cord, you mean? What?
Yes.
Can it be anything else for the sensory symptoms? Only the dorsal column, is it, or you can have other places also?
Sir, one thing is because she's not able to tell whether, because she's able to perceive the clothes and she's able to perceive the mosquito bites. Generally, sensory, we should think of spinothalamic tract also, but here, according to the history, she gave only sensory ataxia symptoms were there rather than she's so only posterior column along with the lateral corticospinal tract involvement we are thinking of.
We had a proprioceptive difficulty, right? Yeah, sir. You can ask Sir Ujjwal, sir.
Yeah, about the level in the spinal cord, cervical, dorsal, lumbar, where it is. That is the first thing that you need to.
Yes, sir. First, initially localization to spinal cord, and then because of involvement of both upper limbs and lower limbs, cervical cord, I'm thinking also.
What level of cervical cord?
The question is, can it be?
Sir?
Hello. What level of cervical cord do you think it will be?
According to history, because weakness is there in proximal upper limbs, it should be above C5 of C5 levels.
Okay. And can it involve cervicomedullary junction?
Possibility is there, sir, because cervicomedullary junction involvement causing quadriparesis possibility is there, but in the history there is no any respiratory difficulties or any other cranial nerve involvement or any neck movement related issues were not there. So possibility of cervicomedullary junction involvement is also there.
Okay. Dr. Muttu?
Yes. So this sensory ataxia, I mean, you had predominantly proprioceptive deficits, right?
Yes.
So can it come from anywhere else? Sorry. Like, just a minute. Can you have involvement of the dorsal root ganglion or peripheral nerve, which can present with proprioceptive deficits?
Peripheral nerve involvement can have proprioceptive deficits.
No, just that because you are localizing the structures, you just wanted to know if you want to involve other structures also, or only the dorsal columns. So with dorsal root ganglion?
Dorsal root ganglion possibility is there, sir, and peripheral nerve involvement is there, and radical involvement also, sensory ataxia we can have.
So that is it. And limb weakness also, is it, how do you say it is corticospinal involvement alone? From the history?
Actually, from the history, because there is limb weakness, we can attribute it to corticospinal tract, and radical involvement also we can consider, sir, but because of symmetrical involvement of weakness and symmetrical history, here I thought bringing only corticospinal tracts rather than considering radical involvement.
How about, say, I mean, you have a sensory loss, you have weakness. Why not a polyneuropathy?
Student present.
Hello?
Yes.
No, we're just dissecting the history. Just you can answer.
Sir, because along with polyradiculopathy, because here there is involvement of first initially started with neck pain and both motor sensory and bladder involvement made us think about localizing in cord rather than polyradicular neuropathies.
Okay, fine.
What are the pathologies you think are possible?
Sir, possible pathologies, it can be both non-compressive cord etiology or compressive cord etiology.
You are saying distal to proximal weakness with there is spasticity, like symptoms are there. So then why non-compressive?
Because sir, one history, there is no history of any neck pain history was there with there is no history suggest of any radicular pain or any dermatomal distribution history was not there. Because of symmetrical history, they thought of non-compressive than compressive. And one more thing is early bladder involvement when we thought of non-compressive than compressive lesion. And because in compressive lesion, generally the neck pain and the radicular pain and dermatomal distribution will be there, and bladder involvement generally will be late. And symmetrical involvement is also because of that thought of non-compressive comparatively with compressive lesions.
Dr. Santosh, and
Yeah.
followed by Dr. Elevaris, they wanted to
Yes,
ask the
yes,
question.
madam. As Dr. Muthu asked, so Dr. Sujit, why not radicals? Because there is spasticity. So why only corticospinal tract? Because spasticity cannot happen in radiculopathy. Either it is a myeloradiculopathy or it is a myelopathy. Simple radiculopathy cannot produce spasticity. So that is or here there is spasticity is there na. So you cannot localize to simply radiculopathy isolated. It may be myeloradiculopathy or it may be only involvement of the corticospinal tract.
Okay, sir.
Also in extradural lesions, you have mentioned peripheral nerve sheath tumors. So it is very unlikely because they are usually unilateral. You have bilateral symptoms to begin with, symmetrical. So that does not get into the picture, peripheral nerve sheath tumors. And
Okay.
very unlikely they will cause from beginning spasticity also.
Okay.
Which will be usually a late feature once the cord starts getting compressed. So that is something that you need to, that gets ruled out.
Okay, sir.
Along with CVJ anomaly, syrinx, can you think of that? Is that a possibility?
Syrinx, syrinx possibilities there, sir, but there is no dissociative sensory loss symptoms were not there, and like it's a contralateral loss of pain and temperature history was not there, so not thought of syrinx here.
Okay.
Adding on to Dr. Ujjwal's question regarding non-compressive versus compressive, you already mentioned about there's no presence of radicular pain. So there is no history of
Yes.
Lermits. There is no sensory level here,
Yes,
and
ma'am.
and bladder is also present. So that are other features which why there favor non-compressive rather than compressive pathology here. Dr. Elavarasi, please ask.
Yeah, regarding the localization part, I wanted to add that we were discussing about a possibility of radiculoneuropathy or a myeloradiculopathy versus a myelopathy. I think the point that actually probably clinches the localization to myelopathy is the presence of the overactive bladder or the UMN bladder. So had there been a LMN bladder or a retention or a poor urinary stream, then that would probably go in favor of a radiculopathy or probably a coexisting myeloradiculopathy. But presence of UMN bladder is going to pinpoint the localization to something above the level intrapontine and suprasacral segment.
You can proceed, Dr. Sujit, for the examination.
On coming to the examination part, on examination, patient is conscious, oriented to time, place, person, and obeying commands, afebrile, and BP on supine position at 110/70 mm HG at right upper limb, and pulse rate is 70 beats per minute with no tachypnea, no pallor ictus cyanosis, clubbing, and lymphadenopathy and pedal edema, no hyperpigmentation of skin, and neck length ratio normal, and catheter was in situ, and other system examinations like cardiac, respiratory, and GI was normal. On examination, higher mental functions were intact. Cranial nerves, no abnormality found in cranial nerves. All cranial nerves were intact. And coming to motor system examination, no wasting noted, and tone, according to modified Ashworth scoring, spasticity was more in lower limbs compared to upper limbs. And grade motor power, there is pyramidal type of pattern of weakness was there, where extensors in upper limb are affected more, and flexors in lower limbs are affected more. With bilateral finger grip was moderately weak, and here in power, neck muscles flexion and extension was good. There is no involvement of neck muscles, but involvement of upper limb and lower limb followed the pattern of pyramidal pattern weakness. And reflexes, deep tendon reflexes coming from in upper limb, biceps, triceps, and supinator were brisk, knee, ankle, and brisk, and pectoral reflex, it was brisk bilateral, and plantar being bilaterally extensor, and abdominal reflex absent in bilateral, jaw jerk normal, and anal tone was increased. Sensory system, coming to modalities in sensory system, pain temperature was intact in both right and left side, and root touch and fine touch were equal on both sides, right side and left side, and vibration impaired at and below till vibration was at the start of grade was till C7, it was impaired in both right side and left side. And examination of joint position sense, impaired at great toe, ankle, knee, fingers, and wrist and elbow, both sides, both right and left side. And thromboxane couldn't be assessed, and gait not able to assess, and cerebellar signs were no abnormality in cerebellar signs, and no signs of meningeal irritation, and there is no any spinal deformity or spinal tenderness. So, summary after examination: symmetrical UMN type quadriparesis with hyperreflexia and bilateral extensor plantar response with impaired posterior column sensations, and sensory level being above C7, and motor level above C5, and reflex level above C5. And coming to anatomical localization after examination, symptoms like paresthesias and wash patient phenomena, imbalance while walking or swaying while walking. Signs we got after examination were sensations impaired below C7 and joint position sense impaired. So I want to localize it in dorsal column, and difficulty in moving upper and both lower limbs, and stiffness of limbs or spasticity. So signs after examination were like weakness and quadriparesis with level above C5, and with brisk reflexes and normal jaw jerk, corticospinal tracts above C5, and urge incontinence, bladder involvement like UMN bladder involvement with involvement of descending atomic pathways running down the cord. So clinical features and signs and symptoms suggest of dorsolateral cord involvement above the level of C5.
What are your, once again, what is your anatomical localization craniocaudally and horizontally in the axial section of a spinal cord?
Sir. Horizontally, substrates involving one thing is corticospinal tracts are involved, and descending autonomic pathways of the cord which supply the bladder were involved, and dorsal column or posterior column was involved. These were horizontal substrates which I want to localize there, and vertically, because we got motor level at C5 and sensory level at C7 and reflex level at C7, it should be above level C5. It can be medullary cervical junction or any like above C5, vertically substrate involvement. And because of involvement of both upper limb and lower limb, so long
Okay. And what pathologies you consider?
Because we are thinking in terms of non-compressive myelopathy, it can be inflammatory or infective or nutritional or any vascular and demyelination or paraneoplastic etiology is thinking of.
Okay. Why non-compressive?
Here, same like after examination, because of involvement of bladder, because of involvement of early bladder involvement and symmetrical involvement of upper limb and lower limb muscle motor power, and with involvement of sensory, thinking of non-compressive rather than compressive etiologies.
Yes,
So,
Dr.
Sujit,
Sir,
so this sensory, can you go back to sensory examination? Okay, so you have said the fine touch and crude touch are equal, and you are wanting to attribute dorsal column involvement. How would you how do you think you would explain that finding?
maybe actually fine touch will be by dorsal column involvement and crude touch with anterior spinothalamic involvement, because here there is involvement of dorsal column, there can be impaired fine touch, but because root touch is intact because of anterior spinothalamic intact, because it was bimodal supply. So maybe she impairment will be patchy involvement, or she could not be perceiving the loss of fine touch or crude touch, because she's feeling the same way all over the body, because crude touch is by anterior spinothalamic and fine touch by posterior column. Only loss of posterior column without loss of anterior spinothalamic tract can explain this, because she might be feeling same way all over the upper limbs or lower limbs.
Yeah, high cervical cord lesion, maybe face also is involved, so difficult for her to appreciate the difference. Probably that is,
Do you want to check cortical sensations in this patient, especially that you have said the fine touch is equal on both sides?
No, so because if all modalities in this sensory, primary sensory is normal, then we go for cortical sensations. Here, I don't think there is a requirement to look for.
We have said it is equal, no? It's
Yes,
all
sir.
equal. So did you test the cortical sensations?
No, sir, because we thought.
Okay, I think it's better to check it, because especially when you say the fine touch is normal, it is important that you check the cortical sensations also. And for posterior column, what specifically would you test in sensory examination?
For posterior column, we check for vibration and joint position sensor.
No, other in touch, I'm asking. So how do you differentiate crude touch from fine touch?
Like while examining.
On examination.
On examination, fine touch will be like with cotton will test for fine touch. Whether
Crude
it
touch?
touch will be with.
No, I think crude touch is the basic sensation of being touched. Okay, it's like somebody says I'm being touched, that's crude. If you want a fine touch, then you should be able to localize the touch, and you should be able to appreciate the pattern, the texture of whatever you're touching with. That is important. And if you want cortical sensations, then you need the 2-point discrimination, stereognosis, graphesthesia, all those things. So these are at different levels of the same pathway. So texture is the cord. Then once you go to the cortical level, 2-point discrimination happens, because that depends on the sensory homunculus. So what is the area represented there? So in the fingertips, you have a very small, 1 or 2 millimeters, you'll be able to discriminate, but on the back, you won't be able to discriminate that much. You need 10, 12 millimeters sometimes. So that depends on the homunculus. It's a cortical function. And other things like graphesthesia or stereognosis or stereognosis, all those things are also you require the cortex. So basically, you want to localize between the cortex and the dorsal column and crude touch. You have to actually examine. Once you crude touch is normal, you have to go to the fine touch. Then you have to examine the cortical sensation. That is normal. I think that is something you can go with also. Fine.
Oh,
And
okay.
yeah,
Dr. Elavarasi
so that
has.
okay. I think I'll leave to Elavarasi, madam. Yeah.
Sorry. Actually, I wanted to ask the first symptom that you said was pain in the neck, right?
Yes.
So when we're talking about pain, are we talking about a radicular type of pain? Is it a funicular type of pain, or is it a bony pain related to musculoskeletal involvement? Because that is the one which is going to give you some direction whether it is a compressive myelopathy or a non-compressive myelopathy. So in the era of imaging, whether it is compressive or non-compressive, the only definite way is to do the imaging and find out what it is. But if there is localized pain and localized deformity at a particular level, then probably that will direct you towards a compressive etiology. So can you describe more about the pain in this patient?
Pain, actually, she complained of neck pain, which is actually poorly localized, and non-radiating pain and dull aching pain. And there is no any dermatomal distribution of neck pain radiating to any specific dermatomal distribution is not there. Only dull aching pain and poorly localized. So morely, we thought it could be funicular pain rather than radiating pain.
In
And
that case,
Any
we are
factors
sorry.
which aggravate or relieve the pain?
with any neck movements, flexion, extension, and sideward movements. So local muscular etiology or musculoskeletal etiology was ruled out.
If we are thinking of a funicular pain, then we are probably attributing that to involvement of the spinothalamic tracts. But on examination, you did not find anything relating to the spinothalamic tract. So, is it possible that it is something like a CV junction or a bony lesion that is leading to the pain, or maybe a extradural compression?
So, yes, that's why like CV junction anomaly is also in the DD SNAM, but for CV junction anomaly, some trauma or some trigger should be there for increase in the symptoms or the presentation. But here there is no any trigger or there is no trauma which aggravated the event of the symptoms.
Intramedullary pathologies can also present with pain, dull aching pain, which has no specific features of radiculopathy or something.
Yes, sir.
Yeah, that
Yeah, so,
intramedullary pain is attributed to the involvement of the spinothalamic tract, the funicular
yeah.
pain because
So,
of intramedullary lesion.
okay, you can proceed.
Okay. So after the examination also, like we kept the broad differentials like by etiology localization in non-compressive, like it can be demyelinating lesions or infections have to be ruled out, and inflammatory, vascular, nutrition, and paraneoplasty. And apart from non-compressive, thinking of compressive can be central disc protrusion or extradural lesions, and intradural extramedullary lesions, and CV junction anomaly. And then after examination,
After history, it is okay if you keep both possibilities, but after examination, you will have to
now,
narrow it
okay,
down to something either compressive or non-compressive.
okay, sir. Unlike, okay, sir.
So, what do you think?
So we thought of non-compressive lesions. So first we thought of evaluating by doing MRI, MRI spine with contrast, and then we proceeded further. So shall I proceed to investigation, sir?
Yes, Sujit. Yeah, please show me.
Okay. So on presentation, first we want to do MRI cervical spine with plane and contrast. So here T2 sagittal section or T2 of sagittal section of cervical spine showing the T2 hyperintensity. that is sagittal section, and axial section T2 showing the hyperintensity. T2 with contrast. T2 sagittal with contrast, showing hyperintensity almost from C2 to T4 level with posterior cord enhancement and along with the anterior cord enhancement. This is T2 sagittal with contrast showing the hyperintensity and contrast enhancement in both posterior cord enhancement with slight anterior cord enhancement. T2 axial section with contrast showing this enhancement in the posterior cord enhancement with central canal extension with mild anterior surface involvement, giving you
What is your diagnosis based on radiology?
based on radiology. After seeing both the T2 sagittal axial, there is a long extending transverse myelitis where it was extending from cervicomedullary junction almost from C2 to D4 level.
Can you show the T2 ones?
Sagittal, sir.
Axial. Dr. Sarvesh, any comments?
Yeah, hi. So actually, when you're describing this kind of lesions, now you should call it. It is a longitudinally extensive myelitis, right? Extending for more than 3 vertebrae. And in the axial scan also, it is a transversely extensive. Okay, so it's like the entire circumference of the cord is involved. In the SAG contrast image that you were showing, right?
Yes.
So one more thing is there in the T2 size, the cord is expanded. That's also one more thing, right? Most of the transverse myelitis that you see, that expansion is not that much. This is a kind of a tumorous kind of enlargement. The cord is extensively expanded. The anterior, the ventral, and the dorsal CSF spaces are all effaced. So there is expansion of the cord. It is longitudinally extensive. It is transversely extensive. And if you play the contrast image, you can play this one. You can just play this. Yeah. So the one that you told anterior is actually central canal enhancement. So there is a dorsal enhancement that is quite evident in this case, and the one that you're calling it as a anterior cord, it's actually a central canal enhancement. Okay. So there is enhancement, but there's a pattern to it. It's predominantly dorsal cord as well as the central canal enhancement. Yes. Okay.
Okay.
And in the axial scan, apart from the central canal enhancement, you have the anterior pial enhancement also. So if you see the axial one, so you have the dorsal cord, fine. You have the central canal, okay, that connection that you see between and then you have the anterior pial surface also enhancing. Okay, so you can proceed with your differential diagnosis here. And what do you think?
Yes, here in T1 contrast in axial, there is posterior cord with central canal involvement giving a sign called like trident sign.
Okay, so is this sign of any importance, any significance?
Actually, it's not a diagnostic sign, sir, but classical sign we'll see in either sarcoid or lymphoma.
Okay, so are there any other differential diagnosis? If you see the T2 SAG, the signal intensity is actually extending from the area postrema, I mean from the obex where the central canal starts. So NMOSD is usually a differential for all the kind of condition. However, the enhancement pattern is quite different, right? So so NMOSD, lymphoma, and any other differential diagnosis So last week in the Green Journal, there was an interesting case published. So they have described GFAP astrocytopathy as one of the differentials for the trident sign. Okay, so there are four. These are the top fours for the trident sign, and people say HTLV is also a differential, but generally the enhancement is absent in that kind. It is not common to see enhancement. So these five are the top differentials. Okay, you can so it is your neurosarcoid, your NMOSD, lymphoma,
Neurosarcoid,
GFAP,
NMSD, lymphoma,
and
GFAP.
yes. So these are the five differential diagnoses. Why do this trident? If it is a trident, why does it happen? Why does it occur? This kind of enhancement, why does it happen?
Because subpial posteriorly cord involvement with central cord extension giving that appearance of trident appearance. Because
Yeah. So whenever,
posteriorly,
yeah, exactly. Whenever you see this trident appearance, it is basically leptomeningeal disease. So in
yes,
lymphoma, it is lymphomatous involvement of the leptomeninges. In sarcoid, it is granulomatous involvement of the leptomeninges, right?
yes, sir.
So in GFAP also there is perivascular involvement. So whatever it is around the vessel, and that's why you get the surface kind of involvement that gives. There is also something called a reverse trident sign, which is also described with neurosarcoid, where rather than the dorsal enhancement, you have a ventral enhancement. So basically, it just suggests that there is a perivascular and a leptomeningeal pathology happening here. Yeah.
Yes. So,
Elevarasi has
any other pathologies that you can think of that are possible?
actually, sarcoid we thought of
Metastatic
after seeing
metastatic disease.
mets can think of mets, sir, but this particular involvement of posterior cord with perivascular involvement and central canal involvement, we kept differentials for neurosarcoid, lymphoma, and NMO.
No, what Dr. Ujjwal is saying makes sense. See, if I were talking about leptomeningeal pathology, right? If there
Yes.
is a metastatic leptomeningeal, I mean CSF dissemination along the leptomeninges, it will also cause this kind of cord inflammation. Cord will be enlarged, and you can have enhancement. You may not get the classical sign, but similar to it, you can have leptomeningeal. So that leptomeningeal metastatic pathology can also be a differential to these kind of conditions. And
But
if you have interparenchymal lesion, you get something called a flame sign, where there will be a deposit in the center of the cord. Along with that, a halo will be there. That's called a flame sign, or there is rim sign. So these two signs are there when we get a metastatic disease in the cord. If it is a parenchymal, so we can have two kind of patterns. The metastasis can be within the cord, that's a parenchymal metastasis, or it can be on the leptomeninges, like in that you see in a CSF dissemination.
because history wise, there is no involvement of other system like any weight loss history or other constitutional symptoms were not there. So, metastasis, we didn't thought of any carcinomatous or leptomeningeal carcinomatous metastasis involvement.
So, hi. Can I speak?
Yes, madam, you can ask.
So yeah, I wanted to. I would agree with Dr. Sarbesh. So as you showed in the T2 images, the cord is definitely expansile, and when we compare the post-contrast T1 and the T2 images, it seems that the extent of enlargement of the cord is much more as compared to the extent of contrast enhancement. So the contrast enhancement is patchy, and it predominantly in this patient is involving the posterior dorsolateral cord. That is very well explaining your patient symptomatology and has a very good clinical and radiological correlation. So would you like to comment on pathologies that lead to such patchy cord enhancement and try to move your differentials towards that?
Patchy involvement like neurosarcoid will also have this patchy involvement, whereas lymphoma will have that homogeneous involvement, and NMO will have patchy involvement.
Yeah, you rightly said. Basically, inflammatory pathologies and etiologies like a demyelinating disorder, like NMOSD, they can have patchy involvement because of
Yes, ma'am.
certain areas the blood-brain barrier is breached, and in certain areas there is just bland inflammation and the blood-brain barrier is not yet breached. On the other hand, usually in patients who have tumorous enlargement, those patients have a diffuse contrast enhancement. And NMOSD, even though it is a non-tumorous cause of myelopathy, can be associated with loss of the CSF cord interface and bulky appearance of the cord, even though it is a non-tumoral etiology.
Okay, you can proceed, Sujat.
And my brain screening was done, which was then normal and no any abnormality was found. And after MRI spine with contrast, revision of differentials like all compressive lesions involving that PAVD disc protrusion and extradural lesions and intradural extramedullary lesions were ruled out, still keeping leptomeningeal metastasis and hematological malignancies like lymphoma into consideration. And CV junction anomaly was ruled out. And among non-compressive lesions, like we just discussed, NMO, still GFAP possibility were there, but multiples because of long extending transverse myelitis, MS has been ruled out, and infections has to be ruled out like tuberculosis, Lyme's disease can present like this with syphilis, myelitis associated with syphilis can be present like this, and inflammatory Sjogren's myelitis or SLE, Behçet's can present like this, and vascular dural AV fistula where venous congestion will be there can be thought of, but after MRI that has been ruled out with nutritional B12 deficiency that has been ruled out. So after MRI, then these differentials have been cut down to a small limited number of differentials and then went for blood investigations. Blood investigations, their CBC or renal parameters, blood parameters or renal parameters and liver parameters were normal. And vitamin B12 we have done, which is, but she received outside supplements, which were more than 1000 picogram per ml. Otherwise, CRP is around 20, and serum ACE levels we have done, which is normal 14.3. And for vasculitic workup, we have done ANA profile and ANCA profile, which was negative. And for NMO associated disease or MOG, we have done sent for NMO and MOG antibody panel, which was negative. And for syphilis, VDRL was done, which is negative. Serology was negative. And for look for any other systemic involvement, HRCT thorax was done both for any look for neoplastic or paraneoplastic or any sarcoid mediastinal lymphadenopathy is there or not. HRCT thorax was normal. And ultrasound, we didn't find any source for any other etiology of neoplastic etiology was found. Then CSF study was done where cell count was around 135 cells with a differential count of 95% lymphocytes and 5% polymorphs with protein 91.4 showing pleomorphic lymphocytic pleomorphic pleocytosis with CBNAT negative and meningoencephalitis panel profile and mycobacterium culture negative. Visual acute potentials was we have done and showed normal latency of P100 latency was normal. So after lab investigations and MRI, we thought of differentials like one thing is neurosarcoid, where involving isolated spinal cord with and one more lymphoma with NMO, and as our role will add that GFAP also into consideration for the trident sign with after the ruling out all other differentials with blood investigations and CSF findings. And then we thought then NMO spectrum disorder, then NMO and MOG antibody panel, it came negative. So we thought we are in consideration of whether to consider neurosarcoid involving isolated spinal cord or spinal cord lymphoma. Then to differentiate from radiologically whether it is spinal cord lymphoma or isolated neurosarcoid, then they can look similar and they can give trident sign appearance. But only one report of lymphoma with was reported with trident sign, where more commonly trident sign was associated with sarcoidosis. And more important thing, where T2, where lymphoma usually hypo-intensity will be there, whereas in sarcoidosis, the T2 will be hyper intense. And generally, lymphoma diffusion restriction was there, where in sarcoid there won't be any diffusion restriction. So after considering lymphoma or sarcoid and looking after the T2 hyperintensity and trident sign, and there is no diffusion restriction in DWI spine, so we thought to consider sarcoid over lymphoma here. Then further evaluation for lymphoma, we have sent for flow cytometry to look for polyclonal pattern, where it came negative for monoclonal proliferation of lymphocytes. But other things like PET CT and biopsy was planned, but PET CT, a patient due to some financial constraints, PET CT was not able to do, and biopsy they are not willing because of risk involved in biopsy. They are not willing for the biopsy, and PET CT, because of some personal financial constraints, we couldn't do, and further monitoring, like to look for any hypermetabolic areas, it couldn't be done. So then we came to the final diagnosis of isolated spinal neurosarcoid, where she was treated with IV methylprednisolone with 1 gram per day dose for 5 days, followed by an tapering dose of steroid, which she had clinical improvement and she got discharged. And then again, after she got discharged and she's doing well. Later, she had stopped the steroids, where after 1 month, she had recurrence with the same complaints, where recurrence with same complaints like increase in weakness of both upper limbs and lower limbs with paresthesias. Then again, she got admitted for the second time, and second time T2 SAG cervical spine, showing the extensive lesion which has increased compared to the previous MRI. T2 SAG and T2 axial, showing diffuse increase in the lesions, both in T2 SAG and T2 axial. And contrast enhancement has been done in the second admission, where there is more compared to the first one. So MRI is showing this increase in size of the lesion after stopping steroids. Then because steroid dependence or
Dr.
steroid
Sujit,
effect.
hello, Dr.
Yes.
Sujit, did you consider any time doing biopsy, at least after having a recurrence?
Yes, sir. Actually, plan was there since first admission and second admission. Also, plan was there to do biopsy, but after risks explained to the attendant, they are not willing for the further, like they are not giving consent or not willing for biopsy because of risk involved.
What kind of risk was explained to them for biopsy?
Because of biopsy from the cord, the risk explained was like functional loss might be there.
Okay.
So in second admission, because of that steroid refractory or steroid dependence, we started to methotrexate. The second line immunosuppressant methotrexate was started, and in that, along with, because of that aggressive nature of the disease, along with methotrexate, we have switched, along with methotrexate and tapering steroids, we switched to monoclonal antibody adalimumab. Then after 3 months, again for follow-up, MRI was done after she had received adalimumab with dosage of 40 mg every 2 weeks subcutaneous she is receiving. Then after 3 months, this was the repeat MRI after 3 months of receiving adalimumab, and showing almost complete resolution of hyperintensity in the cord. This was recently done for follow-up MRI after she received adalimumab along with methotrexate and tapering dose of steroids. Almost T2 axial section showing almost resolution of the hyperintensity which was there earlier more was there in second admission and first admission. Almost resolution of lesions were there.
What was the
Um,
clinical improvement that was noted other
yes, sir.
than radiological?
Both she had both clinical and radiological improvement. Clinically, now she is able to do activities with upper limbs almost she's able to do in the upper limbs. Lower limbs, now she's able to walk with one man support, and bladder symptoms were resolved.
What about the tone, the spasticity that was there?
Sir, upper limb spasticity is completely resolved, sir. Lower limb spasticity, very mild, like grade, according to that Ashworth scale grading, only 1+ grading was there. Otherwise, now she's spasticity is completely improved, but weakness, she's able to walk, but with one man support. Patient improved significantly after adalimumab, as seen by resolution of lesions in MRI. Currently, she is clinically stable with good recovery. Because of this better improvement after starting of adalimumab, and the diagnosis of neurosarcoid was made before, and we started this adalimumab and methotrexate with tapering steroids, and now she's fine, significantly improved with clinically and radiologically, and currently she's stable and had a good recovery over the period of time.
So what was the dose of adalimumab you used, and how many doses have been given before this MRI?
Sir, before actually she's receiving adalimumab since 3 months, sir. With a dose of 40 mg subcutaneous once in 2 weeks.
Did you give any higher doses to start with for induction, or it was 40 mg?
No, sir. We haven't started with any induction dose. We started with 40 mg subcutaneous dose. Every 2 weeks we are giving, which is subcutaneous, and she's been continuously taking it regularly and with follow-up. And generally, the regimen is like until 1 year it has to be continued, and within up to 18 months to 24 months we have to observe the prognosis and improvement both clinically and radiologically. Then we have like tapering or stopping of adalimumab can be thought after giving at least for 18 months. So then in recent studies also,
how do you plan to monitor disease activity?
Sir,
no, how do you plan to monitor disease activity? Is there any way you can monitor the disease activity?
Thing is, MRS we can monitor disease activities or whether weakness and
MRI
MRS
is not good. Are you considering PET scans to look for any disease activity later, or?
Yes, PET scan we can do for monitoring, sir, but slowly, because patient is improving, we have to counsel them again for any, whether if they're willing for PET scan, actually monitoring has to be done with PET scan.
Sir, Ujjwal, sir, I have a question for you. As neurologists, we are very, very hesitant to do biopsies. So will be helpful if you can tell about the risks and what biopsies are actually safer, what is risky, and the actual patient, what risks should be explained to a patient
So
when we are
I want
finding them for a
Dr.
biopsy.
Sarbe's opinion. Is this completely intramedullary, the enhancement that we are seeing, or is it extramedullary? I mean, posterior to cord?
Yeah, so this condition actually it is involving the surface of the cord. You have primary surface involvement, and then the posterior, the dorsal column is getting involved. So you will have leptomeningeal disease here in this particular case. And, yeah.
So I think biopsy can be done. Obviously, there is risk associated with biopsy. There is a possibility, since we will be approaching posteriorly and doing a biopsy from posterior, and there is a risk of posterior column sensations getting affected. But we are not going to take that bigger chunk as we are doing biopsy. So the risk associated will not be extensive, and it can be done. if there is a diagnostic dilemma, it should be like, since you are saying that there is a classical sign of trident sign is there, so your the first diagnosis is sarcoidosis. Also, intramedullary lymphoma, spinal lymphoma is as such quite rare. It's not really common. So that is something goes against lymphoma. But some metastatic disease is something which I think probably can be higher up in the differential diagnosis. And in such situations, yeah, biopsy can be done, and it is associated with it, but it's not really uh, something which is contraindicated or can lead to adding on to the deficits which patient already have.
So, in cases where you have an intramedullary lesion, many times, sometimes we mimic demyelinating lesion also, and
Mhm.
whether where the workup is negative for all demyelinating pathologies, and we are still in difficulty about deciding whether it's a intramedullary mass versus a demyelination. Would you suggest a biopsy, or would you want to give a trial of steroids and then see and then?
So usually intramedullary tumors or pathology, they have a delayed diagnosis. It takes time because the presentation usually is maybe 6 months to 1 year with a typical pain, and then motor weakness leads us to doing a MRI where we find it. So yeah, if the demyelination is your first suspicion, then we can definitely give a trial with steroids and see if there is improvement. Although saying that even certain tumors will also show some response with steroids. I mean, steroid is a magic drug in terms of getting a neurological recovery. So you will see some response. But if there is obvious heterogeneous enhancement and cystic changes, hemorrhages, all these pictures are seen, then you probably favor intramedullary tumor rather than demyelination. Dr. Sarvesh, do you agree? And based on MRI, we will have certain features will point towards demyelination more than intramedullary tumor.
Yeah, I mean, the most common of these lesions to be confused is NMOSD, because NMOSD can have significant enlargement of the cord. They can be, this they are called bright T2 spotty sign, where the T2 hyper intense, like it might feel like a cyst of a tumor itself. And the enhancement can also be like very feathery enhancement or circumferential enhancement. So that is one thing which can mimic like a uh, tumor. And in mind enhancers, I've seen one or two cases, it falling in that surgical arm. It can happen. That is there. So there, the clinical thing and the pattern of enhancement, involvement of area postrema helps. That is one thing which usually confuses us with uh, tumor, NMOSD. Like this one, it's one particular sign, like you told, possibility of a metastatic leptomeningeal metastatic disease and lymphoma do exist, but then that is what it has to be decided in the clinical meet where we are going to take the patient. Yeah, and I wanted to add one more thing. Somebody in the group has asked about, can we consider IgG4 disease? So I'm not talking about the clinical part, but from radiological perspective, that's a disease which will predominantly involve the pachymeninges or dura mater. In our case, we are talking about more of leptomeningeal enhancement. So that is what is kind of differentiating these two conditions. It is not practically impossible, but less likely than what we're considering here. Yes.
Elavarasi has raised her hand.
Hi. I mean, you said that the patient had some financial constraints, so PET CT could not be done. So, short of a PET CT, did we try to image the chest using CECT chest and abdomen to look for other peripheral biopsiable sites?
Which was normal. And ultrasound was done where there is no any lesions we found. So we thought of rather than going for PET CT, we'll give trial of steroids and immunosuppressant treatment, and we'll see the response.
Yeah, that's a reasonable choice. And as regards to adalimumab, I should say this was a very well managed case because early on you switched to adalimumab, and we know that sarcoidosis is mainly a TNF alpha driven inflammation leading to granulomatous inflammation. So the only thing that we should be careful about here this is at this point this is the perfect style of management, but we do know that several patients with sarcoid later on tend to develop tuberculosis, and patients in the past who had tuberculosis, it is basically a granulomatous inflammation with the pendulum swinging from immunodeficiency side to too much of inflammation leading to autoimmunity side. So these patients may have a relapse in future, and at that point of time it will be very difficult to differentiate whether it is a sarcoid relapse or because of TNF alpha inhibition the patient has landed up in a frank disseminated tuberculosis. So we need to keep the patient under close follow-up and have patient should try to use masks and avoid areas with high incidence of tuberculosis, of course, because in India tuberculosis is found anywhere and everywhere. But I think for follow-up, the patient should definitely be closely monitored
Yes, ma'am.
and
Like
kept under close
monitoring
follow-up.
of adalimumab, where we have initially before starting, we eliminated the ruled out any active tuberculosis, and every 4 to 8 weeks, she's on follow-up to look for any infection risk was there with adalimumab and reactivation of TB risk was there with adalimumab. So she is on follow-up with us, and we have counseled her, and yes, ma'am, she's on follow-up for regarding that risk of TB reactivation with adalimumab.
One more point. This when we are following up the patient, it is prudent that we do MR brain also. I mean, we have talked about biopsiable sites, right? We have talked about CT thorax and abdomen. So, because it kind of involves pachymeninges, leptomeninges, and parenchyma, sarcoidosis, sometimes you might find a lesion in the brain itself, which can be biopsied at a safer site. So, and as a disease progress, you might develop a new lesion also in the brain. So, and the image that you have shown, the first MR, it was a non-contrast scan. So, a contrast is mandatory. We should do only, yeah. The first time when the patient has come in contact, that time the MR that you have shown was a plain outside scan film was there. So, anyways,
Contrast is
follow.
also there.
Oh, okay. So when you follow these patients up, ensure that a contrast MR study is there. And for leptomeningeal disease, do include a post-contrast FLAIR image. So sometime you might find a temporal polar leptomeningeal enhancement or somewhere which can be easily biopsied. That can also give you a histopathological clue.
Okay.
Dr. Sujit,
Sir,
I just want to ask if the patient is clinically improving and we did one MRI almost after 4 5
3
months
months.
and
No, 3 4 months.
3 months, and there is means almost near complete resolution of the lesion. So
Yes.
do we need again repeat MRI unless there is a new relapsed kind of thing?
Yes, sir. Monitoring both clinically and radiologically is required, even though patient is improving, because there is a chance of relapse of new lesions, even though patient is symptomatically not fine. So MRI, both radiologically and clinically, she has to be in follow-up and has to be done, sir.
So even if there is no symptom, we have to repeat after 6 months, 1 year, another MRI.
Yes, sir.
What is the cost of therapy
Sir, this adalimumab, she's getting for 8,000 sir, per dose, and she's getting
per dose, and how
one dose in two
frequently?
weeks. One dose in 2 weeks, sir.
So PET scan will be definitely almost same. So
PET
you could have
scan, yes, sir, but
you have
they were like,
considered doing that.
we'll counsel them again, sir. But they were like,
No,
rather than spending that
now I
money,
don't think so. Initially, it could have been considered because 8,000 per month, she's spending at least 16,000. And how long she's taking this treatment and how long it has to be continued?
This has to be at least 12 months. It has to be continued without stopping, sir. And after that, after 18 months to 24 months, we have to see the clinical progression and radiological regression, and then we have to decide whether that frequency has to be reduced slowly. Then we have to stop. But at least 12 months, it has to be given without stopping.
No, as sir pointed out, so initially patient was in our government scheme. So PET scan was not approved for that under that scheme. So when the
Yes.
patient started improving with some treatment, then they told, okay, patient is improving now. We can do all this. Means we can purchase all this medicine. So
In that time, when we counsel for PET scan, they told rather than keeping 20-25,000 for PET scan, they were like, we'll somehow manage money and we'll give for treatment rather than for investigation purpose and see the trial of management.
Flavors, ma'am, you can ask.
So I agree with the patient's perspective to a large extent because PET scan is ultimately diagnostic and it is going to give you a biopsiable site. Okay, in this particular patient, because you already have done a CECT chest and abdomen and you don't see any nodes at all. Suppose you see nodes, you want to see whether they are metabolically active. Again, PET scan is going to guide you towards the biopsy. Now, in this patient, the patient has already denied to undergo a spinal cord biopsy, and from the based on the background imaging, we are assuming that no other biopsiable site is there. If at all there was uptake, there is going to be uptake only in the spinal cord.
Wow.
So that is true to a large extent. And now coming again to the treatment part uh, about continuing treatment or monitoring treatment with imaging in between. So that is, I mean, there is not a lot of consensus regarding that. Most people feel that if the patient does not have a relapse, then you don't need to image further and continue on treatment. But I think in this context, doing imaging would be to look for other things like, for example, someone is getting when patients are on long-term immunosuppression, patients may develop something like a PML or something that was completely unexpected that you pick up on imaging. So that may be one reason for doing a imaging of the brain and the spine on follow-up. But how frequently that has to be done, whether it has to be done 6 monthly, yearly, or once in 2 years, that is also area of debate. So depending on the patient's affordability, I think we can tailor the frequency of imaging. Now, coming to the third part of continuing treatment with adalimumab, I understand that it is quite an expensive form of treatment. So again, there is no consensus on this part, but there are less expensive medications like once again you can switch and go back to something like methotrexate or even azathioprine is known to be quite effective in patients with sarcoidosis. We do have some patients on MMF who are following up. So later on, once the disease activity has settled, if the patient is continuing to afford adalimumab, well and good. But otherwise, we do have some other options to step down on the medications which are equally effective and maybe more cost effective. That is up to the patient and the treating team to decide, but it could be a reasonable option.
Because the second admission was little aggressive, even though like patient is on tapering steroids and steroid dependent or steroid refractory stage, then when the patient having aggressive sarcoidosis, then better like there are things like better to start with adalimumab or infliximab. Um, so we started adalimumab in this patient.
Yeah, I agree. I agree. Adalimumab is a perfect choice for treating sarcoid, but in the context of cost effectiveness, that's purely from the
Okay.
perspective of cost. If the
Okay.
patient is affording or getting from some government scheme, then this would be the perfect line of management, I should say. Very well
Okay.
managed case.
Dr. Ujjwal, Dr. Muthu, yes.
Thank you,
Uh,
Dr. Sujit. This was an interesting case. Uh, and do you now say it's a compressive or non-compressive?
non-compressive, sir.
Okay. But the history went into favor of compressive, history and examination.
It was towards non-compressive. One, because of symmetry and the early bladder involvement. First, initially we thought of non-compressive, and evaluation went in favor of non-compressive, and finally it came out to be neurosarcoid and patient improved. So non-compressive etiology.
Okay. Dr. Muttu?
Yes, sir. So it was a very nice case. Now that you know it is sarcoidosis, have you evaluated for all the involvement of neuraxis in sarcoidosis, especially peripheral nerves, other things? She has a coexistent neuropathy, or
Yes. No, like actually in this case, one thing for the peripheral neuropathy involvement in neurosarcoid is known. One thing NCS has to be done, but we haven't done NCS in these patients. Or has it?
Sorry if I missed, but have you done viral markers, any immunosuppressants or any history similar to that?
No, sir. Negatives, minor markers, negatives.
Okay.
okay, fine. Yeah, I can finish off your presentation.
Yes. Neurosarcoid, the clinical chemistry of the nervous system, affects 5 to 15% of all sarcoidosis patients, where the immune response being hallmark being non-necrotizing granuloma formation with T cell polarization with exaggerated CD4 T helper cells response with two hit uh, and one more unknown triggered by environmental involvement. And for 50 to 70% of neurosarcoidosis patients, neurologic disease is the first manifestation, involving from top parenchymal lesions, hydrocephalus, pituitary involvement, and stroke, CVT, vasculitis, chronic meningitis, and main cranial nerve palsies involving bilateral facial nerve palsy or facial nerve involvement with optic neuritis. Coming to spinal cord and isolated spinal cord disease and peripheral nervous system, where we can see from radical to radiculopathy or peripheral neuropathy or mononeuritis multiplex, muscle involvement myopathy, and small fiber neuropathy. And cranial nerve neuropathies, most frequent manifestations in sarcoidosis. Cranial nerve neuropathies will occur in 55% of neurosarcoid patients. Involvement of facial nerve, 24% of cases will have, and often the first sign, whether it is unilateral or bilateral. And one important Hereford syndrome, where facial palsy, bilateral element facial palsy will be there with parotid swelling, with uveitis and fever. Prognosis generally favorable, whereas in optic nerve, second cranial nerve, where the granulomatous involvement of optic nerve will be there, we have seen in 21% of cases, where it can be distinguished from multiple sclerosis related optic neuritis, where it has less pain compared to MS, more often bilateral. Prognosis is poor and only 40% improve after steroids. And central manifestations include here leptomeningeal enhancement, parenchymal involvement, white matter lesions, and tumefactive lesions. Like chronic meningitis, where persistence for more than 4 weeks, MRI showing diffuse leptomeningeal enhancement, and hydrocephalus, where 90% cases will show obstructive hydrocephalus and 90% requiring neurosurgical shunting requirement. Parenchymal lesions, where perivascular spread white matter lesions or tumefactive masses with symptoms including headache or cognitive deficit and seizures. And from vertical axis, from myelitis to myopathy, spinal cord, so myelitis presentation will be there with MRI showing longitudinally extensive transverse myelitis with more than or equal to 3 segments. Outcome will be high disability will be there in almost around 40%. And peripheral nerves and muscle, peripheral neuropathy will be there with the small fiber neuropathy and muscle, where very rare involvement of muscle involvement of myopathy, where we can see Tigerman sign in MRI, or most importantly, we'll see the Tigerman sign in PET scan, where there will be focal intramuscular masses. And establishing the diagnosis, in our case, where our case fit in possible neurosarcoidosis, where clinical and MRI consistent with sarcoid with exclusion of other causes, and there won't be any no pathological confirmation. That is comes under possible, where probable clinical and MRI consistent with systemic pathology confirmation, where some other biopsy sites either from lungs, lymph node, or skin. And definite neurosarcoid is like clinically or MRI consistent with nervous system involvement, where biopsy of neural tissue is proved with neurosarcoid. So exclusion of infection and malignancy is mandatory, before diagnosis. And here for hunting, like for look for the biopsy tissues where chest CT can yield about 70%, where we can biopsy sites, or PET scan will yield 78% sites for doing biopsy, and endobronchoscopic ultrasound or true cut fine needle aspiration can be done. But avoid high risk neural biopsy by finding accessible systemic disease. Like if your systemic disease, if any possible or available site was there, can go for other accessible sites. And role of imaging, it will be both for detection and activity monitoring. Detection, anatomy, MRI is gold standard. 79% abnormality sensitivity is there with to look for leptomeningeal enhancement or parenchymal lesions or intermedullary spinal signals. And vascular vessel wall imaging may show subclinical involvement. But activity monitoring, PET scan has to be done, where identifying occult biopsies from lymph nodes or skin to upgrade diagnosis from possible to probable to definite. And CSF and biomarkers were the clues, but not answers, as CSF can show elevated protein or mononuclear pleocytosis, and OCP bands can be present but non-specific. And ACE here has limited value, where sensitivity is only around 67%. And emerging markers being, one thing is soluble interleukin receptor 2, where has 93% accuracy, and T cell profile where elevated CD4 CD8 ratio more than or equal to 5. These are the emerging markers when compared to CSF and ACE. We can go for interleukin 2 receptor and CD4 CD8 ratio. As we ruled out all these mimics differential diagnosis previously, these will be the mimics where we already discussed about how to rule out other things. And therapeutic ladder, where stepwise escalation. Step 1 will start with the corticosteroids, and 71% favorable response will be there with IV methylprednisolone, and high relapse rate 33% will be there. And second escalation will be second line immunosuppressants, including methotrexate or azathioprine, where we use in cases of steroid refractory or steroid sparing diseases. 55% beneficial response will be there. In step 3, third line biologics TNF alpha inhibitors like infliximab and adalimumab, where we will use in severe refractory diseases, and 72% clinical benefit we'll see in the refractory cases. And evolving consensus, phenotype driven approach. Well, after diagnosing neurosorchid standard phenotype, we can follow the stepwise escalation by starting from steroids, then second line immunosuppressant like methotrexate or azathioprine. But in severe phenotype or like severe spinal cord involvement like myelitis or refractory meningitis, severe CNS involvement, early aggression and starting with TNF alpha inhibitor is the best, rather than going for wait and see approach. Bypassing the wait and see approach and going for early aggressive management by starting TNF alpha inhibitor like infliximab and adalimumab will benefit the patient. And prognosis and morbidity, like 1/3 will be refractory, 1/3 remission, and 1/3 chronic control disease. So overall view of neurosorchid from clinical manifestation management, all clinical manifestations, diagnosis, treatment, and
Yeah. Thank you. Thank you, Sujit. We must compliment the treating team for this excellent case, a commendable treatment strategy and timely decisions. Over to Sangeeta, madam, since we've already exceeded time. Thank you very much. Thank you to the moderators for their time.
Thank you,
Thank you.
Sujit, for the excellent
Thank
presentation.
you.
And also,
Everyone.
thanks, Dr. Ujjwal Sarbesh, Dr. Muthukumaran, and Ilavarasi for the excellent discussion. I think we have overshooted the time a lot. So I'll hand over to Saraswati and Jyotsna for further.
Yeah, I have to mention that Dr. Sujit is a first-year DM resident, and the courage and the hard work that he has shown, along with the moderators, to prepare and present this wonderful case. Congratulations to him and
Thank you.
Dr. Satish. So we have given the flavor of pediatric and adult neurology in our session today, where one case was very difficult to localize. We had to rely on investigations and multiple areas of localization. Whereas the second case was we could really come and pinpoint to our localization, and we could dissect out the case beautifully, showing the different perspectives in pediatric and adult neurology. Let me just sensitize you to our next session, which is an off-peak session. It is not a usual academic presentation. It will make you appreciate a journal paper. That is what I will say at this point. And then let us see some surprise elements. We have excellent moderators and people who are going to help the young neurologists present and critically analyze the journal paper. That is all for the discussion. With that, we close today's session. And I thank all of you for being present here. It is all the panelists for adding value to our second wide activity. Looking forward to much more in the coming months. Thank you so much. Thank you.
Thank you, everyone.
Thank you.